Hello, welcome. This is part one of the chapter on circulation. This chapter will cover in three parts. So I'm going to simplify the circulatory system to three components. And the reason I'm going to do this is because there's a whole lot more than three components to the circulatory system. And so it gets very overwhelming very quickly. And so by organizing the information in this way, I think it'll be easier for you to keep track of what's happening at the different levels. And pretty much all of the stuff we're going to talk about in this chapter and the next one, and when we get to kidneys, is going to be related to one of these three factors. So in a system, we have a pump, we have some tubes that connect all parts of the circuit, and we have liquid in the tubes. And that is it, my friends. That is the circulatory system in a nutshell. You got the pump, you got the tubes, and you've got the stuff that's inside the tubes. And you can modify the behavior of the pump. You can modify the behavior of the tubes a little bit. They can, so it's a little bit more complicated than garden hoses. They can contract down. And how much liquid you have in the tubes can go up and down. But pretty much all of the different complicated medications and all the different stuff, it's going to act on one of these components. It's going to affect one or more of these factors. All right, this chapter is all about the tubes. So it's called circulation. It's primarily about the tubes. We will still talk about the pump, and we will still talk about the liquid in the tubes. But mostly it's about the tubes and what the tubes do and the different kinds of tubes. I'm going to stop my share for a second because this looks funny. And I don't know if it looks funny to you. We are going to do that again. Share screen. Oh, let me see if it's this. Share screen. Share. Yep. I don't know if that fixed anything for you, but it looks better on my end. All right. So blood vessels is what we're talking about. And we can organize our thinking about them into levels. Each one of the levels has a unique structure, unique function, and unique disorders. And the disorders I'll cover on the next slide. So basically we have arteries as one level. We're going to separate it into large arteries because it has some unique problems with the large arteries. They direct flow to target organs. What I mean by that is during a time of fight or flight, it's time to send a lot of blood to the skeletal muscles, not so much to the digestive system. This is the level at which some of this control is happening. They have the highest pressure in the systems, and they experience the highest stress on the walls. The small arteries and the arterioles, this is where most of the peripheral resistance comes from, and this is where a lot of the contracting of the smooth muscle happens that manages the blood pressure. Then we'll get to capillaries. These are the smallest of all the blood vessels. These are the permeable ones. This is where stuff can pass from the bloodstream to the tissues and vice versa, from the tissues into the bloodstream. And then we recollect the blood into these larger vessels known as veins. They're the largest volume vessels, lower pressure. The walls are not as thick as they are in the arteries, and the flow is a lot slower. So let's take a look at what problems arise. In the large arteries, biggest problem is atherosclerosis. We get this stiffening and stiffening of the arteries, as well as buildup of some plaques that we'll talk about. We can have bulges in the blood vessels known as aneurysms, and aneurysms can sometimes rupture, which is an enormous problem. Their peripheral arterial disease, we'll talk about that briefly, and arterial stiffness. So arterial stiffness is a more general term. So that's arteriosclerosis, and atherosclerosis kind of falls under that big umbrella. And there's a development of plaque, but there's also stiffening of the arteries. Then in the arterioles, the things we're going to talk about are the two extremes. There's hypertension, where they're contracting too much, and then there's circulatory shock. You know, those vessels aren't contracting enough. The blood pressure is way, way too low. In capillaries, one of the problems we see is edema. We get too much fluid going out into the tissues and staying out in the tissues. And with the veins, some of the problems we'll mention are varicosities, some thrombi, the blood clots that can form, and venous insufficiency. So let's get to it. We'll talk a little bit about how dynamic the system is. The heart and circulation that can adapt to changing demands. That can happen within moments. For example, up on the upper part of this graph, we're looking at heavy exercise. The heart can start pumping really hard and really fast. And these blood vessels can dilate and carry enormous amounts of fluid very quickly, deliver the fluid to the organs that need the fluid. And then within moments after the exercise is over, the heart doesn't stop, of course, but it slows and it doesn't contract quite as hard. And so we slow delivery of blood to the tissues. So I'm going to use these very simplistic terms throughout just to remind you of those three things: the pumps, the tubes, and the liquid in the tubes. So here, what we're talking about is the pumps and the tubes. We can get responses very quickly in the pumps and the tubes. The liquid, the changing volume, that takes longer to adjust. But this is within moments we can get these changes. All right, circulation. I know that you have learned this many, many times. I have learned this many, many times myself. And it was a few years ago, all right, a lot of years ago now, but I had learned this 100 times and I had forgotten this 99 times. And so I thought, I have to find a way to hold on to this information. I know that there's pulmonary circulation and I know there's systemic circulation, but which one is coming from which side of the heart and how can I remember this? And so I finally came up with a way to remember. So the blood that's leaving the right side of the heart is the blood that goes through the pulmonary artery. It's an artery, but it's deoxygenated blood. It just came back from the rest of the body. It's being sent to the lungs to oxygenate. It's going to come back oxygenated, but the definition of artery and vein is not whether it's carrying oxygen or not. The definition is what direction is the blood being carried, and carrying away from the heart, that's an artery. Carrying towards the heart, that's a vein. And then it's coming back, it's oxygenated, it is ready to go to the rest of the body. It returns to the left side of the heart. After it leaves the left side of the heart, it goes out to the rest of the body. It may be going up to the brain, it may be going down to the legs, but the point is it's leaving the general area of the heart. All right, so this is how we're going to remember it. I'm going to have to give you a little bit of a story so that you can picture this better. When I had my first kid, I didn't realize how much the kid is going to stick to me. And this child would follow us everywhere. And so eventually the kid became a little more independent. 2 years old, toddler, we would say things like, I'll be right back. I'm just going to go to the bathroom. I'll be right back, so that this child could stay in place and not follow us around. And then my kids started imitating that. And so in this sweet little voice would say, I'll be right back. and do the little hand gesture. I'll be right back. I'm just going to go to my room. I'll be right back. And so the blood exiting the right side of the heart is saying, I'll be right back. I'm just going out to the lungs. I'll be right back. Just, the heart's here, lungs are here. It's just going out to the side and it's going to be right back. It's not going far. That's also the explanation for why the walls of the right side of the heart are slimmer or not real thick, because they blow out all the blood vessels out here if we pumped it as hard as we do out to the rest of the body. So it's just going out there and back. It's not going to take long. Okay, then the other thing, the left side, so the blood from the left side of the heart. Okay, what I hear in my head is what used to be said. Now, this is predating even me, but Elvis Presley was a really big deal. I was a young person. And people would be fanatically clamoring for his attention. And after the concert, people would screaming. And so they'd have to announce, Elvis has left the building to kind of clear people out. And so this is how I hear. The blood has left the thorax. It's exiting the left side of the heart. I know that on the diagram, it's the right side, but it's the patient's left side. So the left side of the heart has left the thorax. It's going to other places. Yes. All right. So blood exiting the right side will be right back, and the blood exiting the left side has left the thorax. So that's the systemic circulation. And again, that's why the left side has to have those very, very thick walls, because it needs so much higher pressure to push it through all these blood vessels. Then, okay, why two circuits? Why couldn't it just be that simple, like pump and the tubes? And okay, this is why. Because when the blood goes to the lungs, it has to go through these capillary beds, and we lose a lot of the pressure. So when we go from the arteries down into the arterioles and then down into the tiny capillary beds, the blood has lost a lot of oomph. I know that's not a technical term, but a lot of push. And so in order to get this oxygenated blood out to the tissues and carry all the oxygen out to the tissues, it has to do a return trip to the heart and then get pushed again. There is a case where you'll see blood going through two capillary beds. There are a couple of places, but on this diagram, there's one here. The blood that's being picked up from the GI tract. This is the stuff that's, carrying all the nutrients, stuff that you just ate, and then gets picked up into the blood. And that has to get filtered through the liver. Have you ever wondered why so many of our drugs damage liver? The liver is the first line of defense of, poisons. And so that stuff has to go through here before it gets into general circulation. Okay, but it's lost a lot of oomph by the time it gets through the capillary bed here. All right, and so most of the body can't do it that way. So you have these double circuits. All right, let's talk now about the general features. These are similar in arteries and veins. There are these three layers of structures. The capillaries, really, mostly we're talking about one layer. So the inner layer is this single layer of epithelial cells. The term that's used for this is endothelium. I will sometimes catch myself using the word epithelial. I promise I am not trying to make any kind of distinction here. Endothelium is simply what we call the epithelial cells that are lining on the inside of the blood vessels. Then outside of that epithelial cell layer, there are smooth muscle cells, vascular smooth muscle. You'll sometimes in this textbook, you'll see the abbreviation VSM. If you have to look it up, go ahead, look it up until it becomes more second nature. Vascular smooth muscle. This is what provides the pressure control by the tubes. Like the tubes can do something, they can squeeze down. It's this smooth muscle here primarily in the arteries, but also in the veins as well. And finally, the outer layer is connective tissue. As we'll see, lots of elastin in the arteries and collagen as well. This material is covered on these pages. Let's see, what did I want to point out here? So we have vascular compliance. There's some flexibility. It's starting to rain. I don't know how loud this is going to come across on the microphone, so I'm going to try to talk a little louder. The vascular compliance, we have stretchability of the blood vessels, and then they bounce back, recoil. And then how much permeability we have. For example, down in the capillaries, we just have that one endothelial cell layer. So that's where you get more permeability. The vascular smooth muscle is the part that can contract and can help us regulate blood pressure, pressure controlled by the tubes. Oh, I know what I wanted to point out here. I'm never going to test you on what these percentages are exactly. What I want to point out is when you look at where, like if you just take a quick snapshot of where is the blood right now, those approximately 5 liters of blood that we have, where is it all? A little bit is in the heart, some more of it is in the arteries, a little teeny bit is in the capillaries at any given time. The vast majority of our blood at any given time is actually in the veins. And so when it's time to make a big, last ditch effort to bring blood pressure back up, yeah, the arteries have to contract for sure, but then we actually kind of recruit the veins to contract as well, because so much of our blood is out in the veins at any given time. Let's talk some more about large arteries, problems that we see here. Uncontrolled hypertension greatly increases the wall tension. We just said that middle layer is smooth muscle. We end up getting hypertrophy in response. It's a muscle, like any muscle. You exercise muscles, they get bigger. We get hypertrophy. The individual cells get bigger. We may even see some hyperplasia. You may get some more cells. That just makes the blood vessels thicker. It actually contributes to the hypertension complications. Then other problems that we'll see, arterial walls can weaken due to the buildup of atherosclerosis, these plaques that we'll talk about more in more detail, and collagen defect. Let's see, we mentioned briefly, I believe in the genetics section, there's a genetic disorder called Marfan syndrome where the collagen's kind of stretchy and it's not as firm as it needs to be. Folks who suffer from this collagen defect suffer from aneurysms. The big blood vessels can split open. Atherosclerosis, just behind the atherosclerotic plaques, as we'll see, aneurysms will sometimes form. This term about vascular compliance is kind of an important concept to understand. So hydrostatic pressure, this is the blood pushing out on the walls of the blood vessels. And the blood vessel can respond by changing shape. We call that compliance. I think of it as changeability. How much can you stretch? So very compliant blood vessels can hold a larger volume, even at lower pressure. You don't have to push real hard to get this thing to stretch. So that's how you end up with most of your blood in the veins. A less compliant vessel is going to hold a smaller volume that to push those walls open needs higher pressure. But they'll bounce back more. You're going to get a recoil. When the heart relaxes, the artery can come back to a smaller diameter pretty quickly. And I'll show you this and explain what role that plays in maintaining blood pressure. Right here is where I'll explain this. All right, so you know that the heart contracts and relaxes. Contraction is systole, relaxation is diastole. So clearly, when the heart contracts, when the ventricles contract, they're going to push out a big volume of blood into the aorta, right? And the large arteries are going to experience this increase in pressure. Because those arteries can give a little bit, they can stretch a little bit, in some sense, they absorb some of that increase in pressure. And that elastic, the stretching and then the recoiling kind of smooths out that big peak of systolic pressure and then the trough of diastolic pressure. So it keeps the diastolic pressure from falling so low. How to explain? All right, so the heart contracts, pushes a bunch of blood out. When the heart relaxes, the pressure could really tank. But if during systole, the elastic arteries stretched, then during diastole, they can come back and they actually propel the blood along. So they're not pumping exactly, but with a balloon, you know, you blow up the balloon and then it's all stretched out and then you let go of it and there are no muscles in the balloon. It's just elastic recoil. It's just coming back down, but it's pushing air out. So like these big arteries, they get pushed open, and then when they're allowed to relax, some of the blood gets pushed along. All right, so you can think of it as a blood pressure shock absorber. If you've ever ridden in a car, you know that the car goes over lots of bumps, but you don't feel it so much unless you're in a car with really bad shocks. Then you feel every single bump, and that is what happens as we get older. Our arteries start to stiffen, and that's going to lead to a bigger difference in systolic and diastolic pressures. So when the heart contracts, all that pressure is going to get pushed out into the arteries. None of it gets absorbed by these arteries stretching. And so we're going to see this uptick in the systolic number. And then it seems paradoxical, but we actually see a drop in the diastolic number. And that's because we don't have the balloon part, the pushing the blood along when the heart is relaxed. And so we see a bigger difference between systolic and diastolic. That difference between systolic and diastolic, that's known as the pulse pressure. So that's in our older patients, we start to see not only a creeping up systolic, but an increasing pulse pressure, a bigger difference between systolic and diastolic. So having low diastolic measurement, if you have a high systolic measurement, is not a good sign. It's a sign that the arteries are stiffening. All right, blood flow velocity, it's highest. The blood's going to move fastest in the arteries and veins, and the flow is going to be slowest in the capillaries. It's necessary for the flow to be really slow through the capillaries because it allows for the exchange. So oxygen gets dropped off, carbon dioxide gets picked up, nutrients get dropped off, waste gets picked up. If you need an analogy to think about this, blood is carrying lots of nutrients, and it even carries it, through the aorta and down through all the big arteries, but it's not dropping stuff off at that time. Much like if you know what an ice cream truck is, carries lots of ice cream, lots of goodies to distribute. You'll see them sometimes on the highway, but they're not distributing, and they have the ice cream in there, but they're not distributing on the highway. Things are moving too fast. There's no time for exchange. They have to get off the highway onto the smaller roads, access road, finally get into the neighborhood, slow down so that it can give up the goods, pick up the cash, and then come back to headquarters and refresh. All right, I know it's a simple analogy, but it helps to visualize this a little bit, I think. Now let's talk about something known as shear stress. Sounds awful, but it's actually somewhat good. It helps, the way the cells of our circulatory system respond to shear stress helps us maintain good, healthy blood pressure. All right, so it's highest on arterial walls due to the high pressures that we have in the arteries and the high flow velocity. So the blood is just passing very quickly by the endothelial cells. I think of it this way, like petting. If you have a cat or a dog, if you've ever petted a cat or a dog, and you're going up, this way, you're petting, things are good. And if you start, doing it in a different direction, it's not so good. That causes a problem. So the petting in the correct direction causes endothelial cells to release nitric oxide. We saw this last week. Nitric oxide, no, we said no clotting. The other effect that nitric oxide has is on the smooth muscle, that middle layer of the arteries and veins. It causes relaxation. So the tubes dilate. They bring the blood pressure down a little bit. And as we've mentioned earlier, this also inhibits platelet adhesion, so decreased clotting. Where arteries split, this isn't even a disease. This is just like normal anatomy. Where they split, where they bifurcate, where they branch, you can call it whatever you want. But what I'm talking about is here, where big arteries become two smaller arteries. That's going to be an area of increased turbulence. And even in healthy people, this leads to increased friction, and there can be some endothelial damage. And we actually do see some plaque development. So here's low shear. So it's like the petting like this, damaging the endothelial cells a little bit. And in response to that damage, the body starts putting down cholesterol as a kind of spackle to kind of fix the damage. And that's where the plaque development starts. Okay, then it gets worse. So downstream of the plaque, so beyond where the plaque started, now we get these eddies, we get this blood that's not running in a straight line. There's decreased shear stress, decreased nice petting, so decreased nitric oxide. Remember, nitric oxide was helping us to dilate, to relax the smooth muscle. So we get less dilation and more contraction, so tube constriction, which increases the blood pressure. And then on top of that, we have less inhibition of clotting. And that's in its normal anatomy. This can get worse. All right, so atherosclerosis is where we're talking about this getting bad. It's a chronic inflammatory disorder of the vascular wall. So it's initiated because of the damage, how can I say, which lots of different factors are going to damage the endothelial layer, and the body's trying to repair that damage. Where we see this the most, in order of frequency, the abdominal aorta is where we get the most atherosclerosis, but it's big honking vessel. Coronary arteries, we see the development of atherosclerosis with lots of consequences to it. And then the thoracic aorta, then the femoral and popliteal arteries in the back of the knee, and in the carotid arteries here in the neck. And that's going to create some turbulent flow, which is why we sometimes listen for the flow here to see if we're hearing bruits, we're hearing the turbulent flow through this area. It's an indication that we have atherosclerotic plaque. As a result of the development of this atherosclerosis, we see this can lead to people's death, and it happens around the world. MIs, myocardial infarctions due to occlusion here of the coronary arteries. Stroke, the occlusion is up in the head. Peripheral arterial disease, typically we'll see it in the legs. All right, so early stages of atherosclerotic development. I cannot stress this enough. Our textbook does not stress this as much as I think it should be stressed. What gets this started is the endothelial injury. Without the endothelial injury, the other parts don't happen. So the first step in the development of this is endothelial injury. If you can understand that, it is a lot easier to understand what measures the patients need to take to avoid endothelial injury. The next thing that happens is the low density lipoprotein, or LDL cholesterol. Those particles enter the intima, so get under the endothelial layer from the bloodstream. Then some white blood cells show up, the monocytes. You may remember the monocytes are the ones that once they get into the tissues, they're going to be activated and they become macrophages. The macrophages then contribute to oxidation of the cholesterol and phagocytosis. They take it in. Once they're all full up with this cholesterol, they can't go anywhere, and they become what's known as a foam cell. It's an old-fashioned term. We're stuck with it. Now we know, oh, that's just a macrophage that got itself all full with cholesterol. Okay, and that contributes to this plaque getting bigger and bigger. But again, what kicked it all off was the endothelial injury. Then this goes on. Macrophages recruit more macrophages to the area. So the lesion grows. Initially, that growth actually grows to the outside, so the whole blood vessel gets bigger, and the lumen, the opening on the inside of the blood vessel, that stays pretty big initially. Then we say we're getting into late stage when you start seeing a decrease in the size of the lumen. So some cells in the core die. We have necrotic avascular residue that can split open. Oh, this is an important point. Calcium gets deposited. It makes that plaque more rigid, makes it harder for the body to get rid of that plaque, but it does make it visible on imaging. It's calcium. It shows up like little bones. I mean, they're not bones, but it's going to show up on CAT scans. And so you may have heard of coronary artery calcium scans. That is what we're looking for, is these calcium deposits in the coronary arteries. All right, so the plaques can actually rupture. If they rupture, it's a trigger immediately for platelets to start aggregating. And once platelets start aggregating, you know clots are forming. And so that's where the thrombi come from, is this plaque rupturing. Now, even without the plaque rupturing, the plaque can grow and keep growing, and it encroaches on the vessel lumen, meaning the blood flow through that vessel is getting smaller and smaller and smaller. Less blood is allowed through. And so downstream from that point, you're going to see signs of hypoxia and ischemia. This is what heart failure results from. We're getting less and less and less oxygen delivered to the cardiac muscle because the coronary arteries are getting more and more and more occluded. If then we get the thrombus form, then it's a heart attack. But if this is all happening in slow motion, that leads to heart failure. Right, so here's the diagram. Normal vessel, great big lumen. In the beginning of coronary artery disease, we have development of this plaque, but we can still get plenty of blood through there. But then in the final stages, we're getting almost no blood flow through this little opening. So we're getting progressive tissue ischemia. Now let's talk about aneurysms. They develop distal to atherosclerotic plaque. So remember we said there's laminar flow. That means the blood's just kind of flowing in straight lines. And that leads to the shear stress, which is a good thing. Then we start developing an atherosclerotic plaque that's going to kind of mess up this nice smooth flow of blood. So just behind the plaque, you get blood pushing in all these different directions, and you can get stretching of the blood vessel there. That's what we call an aneurysm. And ultimately, these aneurysms, they can rupture, which is, of course, a medical emergency. Atherosclerotic or atherosclerosis risk factors. The table in our textbook lists things in a different order. And so I want to make sure that that's clear to you, that I'm presenting something a little bit different from what our textbook is presenting. Over on the left, I didn't mess with anything. These are non-modifiable risk factors. Can't do anything about them, but be aware, as our patients get older, they're at higher risk. Males, for whatever reason, are at higher risk than females. Some family history, some racial and ethnic groups are at higher risk. Now, over here, some of the modifiable risk factors. Listed last in our textbook is diabetes. So the diabetes itself isn't the problem. It's the hyperglycemia that results from the diabetes. That is the problem. The hyperglycemia is extraordinarily damaging to the endothelial tissues lining our blood vessels. And so we're finding that one of the biggest risk factors for atherosclerosis is actually having uncontrolled diabetes, having hyperglycemia. What I put down here, elevated LDL cholesterol, yeah, it plays a role, but a much more important role is played by the other things that are initiating the damage, like the hyperglycemia. We also find, I'll get back to the HDL. We also find hypertension is damaging to the endothelial cells, so controlling blood pressure is helpful in avoiding the continued development of atherosclerosis. This one, I can't make this any clearer. Cigarette smoking, it is so damaging. The chemicals that are in circulation as a result of the cigarette smoking are so damaging to the endothelium that this really does accelerate the development of atherosclerosis. So if the patients can stop smoking, decrease smoking, eliminate smoking, it's really, really best. All right, coming back to the cholesterol thing again, elevated LDL may play a role, does play a role, but this decreased HDL, this is the so-called good cholesterol. This is the cholesterol that number increases as our patients start exercising more. So physical activity helps us increase the amount of the good cholesterol that we have. This is cardioprotective. I'll get back to this cholesterol in a little bit. All right, so pathophysiological determinants of atherosclerosis risk. It's just all the stuff I just told you, endothelial vulnerability, things that are going to damage the epithelial cells that are lining the blood vessels, high blood sugar, high blood pressure, smoking, and out of whack cholesterol numbers. Diabetes, the insults are due to the hyperglycemia. We're starting to appreciate more and more and more. Lots of patients who end up having heart attacks and they look like the picture of health. When we look more closely, it turns out they had elevated blood sugar, which we think was damaging the endothelium, which is what gets the process started. Hypertension doesn't help. Again, damaging to the endothelium, the dyslipidemia. Yeah, so invasion of the damaged intima. It's not that LDL is like evil and it only gets in there because the body's trying to repair the damage in the endothelium. Yeah, smoking's bad news. Metabolic syndrome is a repeat of these three things. So metabolic syndrome is its providers' attempt at warning people that they are heading to developing type 2 diabetes and things aren't going to get better. So there's hyperglycemia plays a role, hypertension. These numbers aren't high enough that the patient would be medicated, but they're high enough to give us a warning sign. And the dyslipidemia goes hand in hand with the hyperglycemia. and chronic inflammation, which can go hand in hand with obesity. There is a rare genetic disorder. Our textbook mentions it. I'm not going to test you on it, but you may see it in your career and possibly on a licensure exam. So I'm going to mention it here. Genetic disorder is familial hypercholesterolemia. It's a mutation in the gene that codes for an LDL receptor. And that thing that's on the outside of the cell, it's supposed to, or it's supposed to recognize LDL. It doesn't work right. And so we don't clear, or the patient doesn't clear the LDL, and the low density lipoprotein increases dramatically. Once it's identified, this is usually managed with statins, medications that bring down cholesterol numbers. Yeah, I'll mention it here. All right, so one of the reasons that I suspect that we talk so much about cholesterol levels and atherosclerosis, when the atherosclerotic plaques were first examined in the 1940s and 50s, it was correctly found that it was mostly cholesterol that's in these plaques. That's what that is. And that's where everybody got the idea that cholesterol was so bad for you. What we did not realize was the only reason the cholesterol is going down in there is because there's already been damage to the endothelium. Nowadays, you know that we've seen this big uptick in increased diabetic numbers, type 2 diabetes. We think that the reason that we're seeing the uptick in the atherosclerosis is also due to that increase in hyperglycemia, and having the damage from the hyperglycemia create openings for that LDL to get in there. So on one hand, the atherosclerotic plaques are largely cholesterol. You don't see sugar in there. So it wasn't obvious that sugar was playing this huge role. The carbohydrate level in the person's diet was playing such a big role in this. And the other thing is it's a lot easier to manage people's cholesterol than it is to manage people's blood sugar. We have these drugs known as statins. They're really effective at bringing down people's blood cholesterol levels. But it's not at the heart of the problem. It's not the thing that initiated the endothelial damage. And that's why I keep taking exception to this. Manage the thing that's causing the endothelial damage, and you'll stop having all this atherosclerotic plaque. All right, so going back to this genetic disorder, usually we see heterozygotes, somebody who has one copy of the defective allele, because homozygotes is pretty rare, and the numbers are insanely high, and those patients have very, very high risk of early myocardial infarction. The heterozygotes have a better chance at a longer life, but they do have chronically increased cholesterol levels. I'll just remind you, generally we think of 200 milligrams per deciliter. That's kind of the cutoff. That's kind of high. And these patients are routinely running in the 400 and 500 range. So very high cholesterol numbers. All right, bottom line, targeting this is just a repeat of all the stuff I've been saying. Get them to stop smoking, control the blood pressure, decrease the carbohydrate load, trying to avoid hyperglycemia. And I know triglycerides are a lipid, and they're part of what contributes to that out of whack cholesterol panel. The lipid panel is partly based on the triglyceride number. As soon as the blood sugar comes under control, so do the triglycerides. They go hand in hand. So if somebody's hyperglycemic and then they bring their blood sugars down and they had high triglycerides, that's also going to come down. So manage cholesterol and triglycerides, increase physical activity because that increases the high density lipoprotein. Diet with more whole foods, less processed foods, fresh fish, meats, vegetables. That's going to help the patient control the hyperglycemia and bring the blood sugars down. And weight loss if indicated. And this will be the last slide for part 1, peripheral arterial disease. This is related to that development of atherosclerosis. So it's affecting the large and medium-sized arteries. This is generally in the lower body, in the legs. And we see it mostly in our patients in their 60s and 70s. It's atherosclerosis, right? So what is going to cause atherosclerotic plaque? Damage to the endothelium. So smoking is a huge risk factor, as well as the things that increase damage to endothelium, the diabetes, the uncontrolled blood sugars, and hyperlipidemia. So the symptoms, patients will experience ischemic pain, cramping. It comes and goes. It'll be worse with exertion because you need more oxygen delivered to the skeletal muscle to walk and run. And so that tissue is not being, you can't deliver all the oxygen that tissue needs because you've got the narrowed lumen of the blood vessels. And so the patient may be reporting transient pain and cramping in their legs. How to check for it? You're going to compare brachial systolic pressures and ankle systolic pressures. So yeah, the ankles are further away from the heart, so you expect the pressure to be a little bit lower in the legs, but not 50% of what you're seeing in the arms, right? And so so you compare, how are the pressures comparing? And if you've got a significant drop in pressure between the arms and the legs, this is an indication that we have peripheral arterial disease. And why it matters is the worst case scenario. It's not just discomfort, pain and cramping, but there can be critical limb ischemia. We're not delivering enough oxygen to the tissues. And the worst case scenario is we end up having to amputate a limb. And on that happy note, it's going to be the end of part 1, and we will pick up on the next slide in part 2.